saying if you open any textbook of central nervous system malformation, you will see a description of many, many different abnormalities. But what I want to show you today is that you can see about 2/3 of these abnormalities in the first trimester of pregnancy, so it's a perfect time. And the other thing about the brain is that these abnormalities, for many of them, are very severe, and many of them are not compatible with survival. And that's a very important thing to say, because if a patient has got an abnormality that's not compatible with survival, they don't want a diagnosis at 20 weeks. They don't want a diagnosis at 17 weeks. They don't want a diagnosis at 15 weeks. They want a diagnosis when you're doing your scan at 11 to 13 weeks. And that's why, for the brain, it's so important to examine these 4 sections, because if you do that, it's very unlikely that you will miss major central nervous system malformation. Can I show you? When you look at this head, you can see the ossification of the skull bone. That's a very important thing to see at 12 to 13 weeks of gestation. When you look at 10 weeks of gestation, the ossification you can see on the frontal aspect of the bone at 10 weeks. So if we look at brain malformation, these are the groups of abnormalities: acrania, holoprosencephaly, semi-lobar holoprosencephaly, and the encephaloceles. These are all detectable in the first trimester. If you look at the group that sometimes you will see that you may pick up some of the spina bifida, the posterior fossa abnormalities. And then the biggest group at the bottom is this list of all these abnormalities. You cannot pick these up in the first trimester of pregnancy. But these abnormalities are all rare. Lysencephaly, migration of brain disorders, these are rare abnormalities. If you look at the figures, 2/3 of brain abnormalities fall into this group that you can either always or sometimes pick in the first trimester of pregnancy. So I have already spoken about axial and sagittal section. What I want to do now next is to show you examples of acrania. This is a patient, if we run this clip, of a fetus at 18 weeks and 4 days of gestation who has got anencephaly. That patient did not want that diagnosis at 18 weeks and 4 days. The first question I ask is why was that not picked up earlier? And it was not picked up earlier because she was not aware that she could have a scan at 12 to 13 weeks. If you run this clip, please. This is a fetus with acrania. And if you look, you see that the brain is overhanging the face. It looks like an encephalocele, but it's an acrania. So if we look at the next one, this is the same fetus here at 17 weeks. Acrania, I've already said that you could pick this up earlier at 10 weeks of gestation. And I keep moving further. This is a fetus at 8 weeks of gestation, which you can see acrania. But the problem is, before 10 weeks, the bone is not ossified. And if the bone's not ossified, how are you going to make a diagnosis? Are you just going to rely on subjective assessment of the fetal brain? And the answer to that question is you need to look for the cranial vesicles. And we are presenting our work looking at the cranial vesicles before 10 weeks at the ISUA Congress in Budapest in September. And I hope you're all going to join us in the Congress, where we will be presenting our work on the value of that in the first trimester. Because I think the same fetus at 8 weeks and 4 days, in fact, if you look back as early as 7 weeks, I showed this case to you before. This is a fetus with acrania at 7 weeks and 4 days of gestation. So I think in the future, the way forward is to look at the cranial vesicles and making a diagnosis very early. I'm not saying to you that tomorrow morning that you go out and start making a diagnosis of acrania at 7 to 10 weeks. I'm sharing with you an experience of what we have been doing for 10 years of imaging. But you have to be very careful before you reach and get to the point where you say, I'm confident this is acrania. Because if you do not have a post-mortem, you have no way of ensuring that your diagnosis is correct. So I'm not saying for a second that tomorrow morning that you go into work and you start making a call. I want to share this so you can see that's possible. and a sense learned from it, but you need to develop an infrastructure before you start acting on it, because you have no post-mortem. Very quickly, I'm going to run through these cases because you've seen some of them, and this is just showing the variation. A crania can be so varied. You can see here it looks like it's cystic. This is elongated. It looks a little bit like Bart Simpson. The next one, you can see bilobular. And this one, it's shortened. These are all variations of a crania. Why do they all look different? Why doesn't a crania look the same for every baby? Well, because in pregnancy, the brain degrades, and it all depends where you scan between 11 to 14 weeks, or between 7 to 14 weeks of gestation. That's why it's so variable. You can run those two clips, please. This is the overhanging brain, and this is the irregular brain. So we reported on the 6 subtypes of acrania of the Journal of Lifestyle Medicine, and I encourage you to read the article because it goes through the descriptive process, and I've already shared that slide, and this is another appearance of acrania, looking very similar to a past president of America. And you can see this very early stage, the dilated fourth ventricle, you may see very early pregnancy. So I'll stop there, and I'm just going to move to the next abnormality, which is, I want to share with you, is holoprosencephaly. So for holoprosencephaly, this is a condition where there's failure of cleavage of the brain into the 2 cerebral hemispheres. These are just, I'm skipping through cases of very early diagnosis of acrania to try and gain some time, because I know I'm a little bit over time. If we go back to here, in acrania, you may also see acrania in twin pregnancy. So this is a fetus with twin reverse arterial perfusion sequence, and you see there's no cranium, and in a sense there's no cardiac motion. And this is a different type of acrania, and this is related to a vascular phenomena, not related to failure or closure of the neural tube. So high dose folic acid is not necessary in the group of acrania from trap sequence. And this is another example earlier in pregnancy showing a trap fetus with acrania and the co-twin, which is normal. And you may also have acrania in both twins, and this is a monochorionic diamniotic twin pregnancy. And when you look at this rendered image, thank you, Long, and you can see both fetuses with acrania at a very early stage in gestation. I asked you the question. I want you to look at this clip and tell me, does this fetus have acrania? So as you sweep through the head, you can see the cranial bone, and this is the whole brain outside the skull. But the skull bone is actually present. This is not a cranium. This is a fetus with an encephalocele, or sometimes it was called exencephaly. But the cranial bone is present. Okay, so let's move to cephaloceles. You need to be very careful about cephaloceles in the first semester of pregnancy because they can be very strange. The first thing is I want to share with you some facts and figures. So we published, it's the largest series of cephaloceles with valvocental beta and our unit in Melbourne. We published on 35 cases of cephalocele, and if you look at these, 77% of these are occipital. But be aware, there is a significant proportion of them that are frontal and parietal, and if they are parietal, you will find that parietal encephaloceles are part of amniotic band syndrome. So just be very careful when you see an encephalocele, turn up your game and look for amniotic bands. So in this case here, you see a large posterior encephalocele, but when you turn the gain up in this fetus, this is when it becomes important, you actually realize that there are multiple amniotic bands extending across into this fetal head. And this is the fetus with amniotic rupture. You can see the bands are also extending to his hands. So this is an amniotic rupture sequence. In this case here, when you look at this case here, you can see there's an abnormal profile. It's sloping backwards at the forehead. And you can see there's a defect in the occipital bone. And you can see the midbrain herniated. This is the aqueduct of Sylvius. It's much easier to see when you go to a vaginal scan. You can see the encephalocele. And when I see an encephalocele, I always ask myself, is there signs of Meagher? Before I show you Meagher, the encephalocele may be shown on 3D, and from a patient's point of view, they understand that image more than anything else. So when I see the encephalocele, I next go, now, this fetus in the top here is a tiny encephalocele, cystic kidneys, and polydactyly. And when you see that, you need to look for the gene mutations, of which there are 7 different gene mutations which have been described with Meagher. And you can do that by whole exome sequencing, whole genome sequencing, or specific probe analysis. So in a setting when she goes in for her next pregnancy, you would consider that on PGD, or you would consider doing a chorion biopsy early in the pregnancy. This is the same patient who came back 8 to 9 months later. It's interesting because you had another encephalocele, but this time the polydactyly was in the hands, not the feet. So she then went on to an egg donation program after 2 cases of Meagher syndrome. And this is a fetus with an anterior encephalocele. This case, when you look at it, the first thing that strikes you, well, let me ask you the question. If you do a scan tomorrow, what's the first thing that strikes you when you look at that head? It's called the dry brain. Do you remember I showed you the 4 sections and I said you need to look and see there's fluid in the lateral ventricles? There's no fluid in the lateral ventricles, it's a dry brain. And this is the brain herniating through the occipital bone in the fetus with amniotic band syndrome and an encephalocele. Remember, you need to look for amniotic band. Now look at this case, and look at this case. You see a dry brain, there's no fluid, and you can see that the aqueduct is juxtaposed to the occipital bone. We reported that sign as a very powerful marker for spina bifida in 2011. Look at it. Herniation of the midbrain, there's no visible aqueduct, and this baby has got a tiny encephalocele. But what made us pick the encephalocele was the dry brain and the midbrain shift. Midbrain shift is a very powerful sign for spina bifida in the first trimester of pregnancy. So this slide here shows you've got to be very, very careful about encephalocele. And I'll just say, please read our article in the JUN, because it shows you that you may have encephalocele that look very bad at 10 weeks of gestation and that return to normal by 20 weeks of gestation. Atretic encephaloceles. And you may have other encephaloceles that look absolutely benign, looks okay, the brain is fine, and then the brain herniates later in the pregnancy, so it evolves during the pregnancy. Some evolve, some regress. And that brings with it very significant challenges on what to say to patients when you make the diagnosis in the first trimester. So in summary, 1, look for amniotic band syndrome. 2, look for Meagher syndrome. And 3, be very careful about the natural history in cancer patients with encephalocele. This is a case where I show you my example. I ask you to tell me what you think. You go to work tomorrow morning and you scan this 13-week brain. You do a 4-segment analysis that looks absolutely completely normal. And you bring the patient back at 16 weeks and the posterior fossa looks completely normal. Please run this clip again if you could. When you look at the brain at 13 weeks gestation, you look at the brain at 16 weeks of gestation, look at the fluid, it's not a dry brain. Look at the aqueduct, it's normal. Look at the 4th ventricle, it's normal. The 4-segment analysis is normal. Now, from my point of view, I find it very hard to distinguish between an epidermoid cyst versus an atretic encephalocele. And that becomes very challenging in cancer for the patient. And I may need to rely on doing an MRI later in the pregnancy in cancer for this patient as to what their prognosis is. So there are significant challenges. Meningocele, very quickly, you may have a meningocele which appears the fluid-filled cyst. If it moves to the baby's head, it's a meningocele. If it's in the synovial space, it's not a meningocele, it's a yolk sac. The yolk sac should never be inside the amniotic sac. It's always outside. Holoprosencephaly is a major abnormality of failure of the brain to cleave into 2 ventricles. We first reported on a reduction in the BPD many years ago, and you may also have a very abnormal profile. So if we go back to look at the 4-segment analysis on this, you can run that clip. You see the falx is missing, the choroids are fused across the midline with a single anterior ventricle. And this is the surface rendered image here in a fetus with a holoprosencephaly. The incompatible with survival, most patients choose not to continue beyond the first trimester. In this case here, when you look at it, you can see the abdominal circumference is very small, and you think that this baby's head is big. That's the first thing you think. It's a big head. This is not a big head. It's the abdominal circumference is below the first centile. And that is the typical appearance of digynic triploidy. And typically with digynic triploidy, they will have a negative cell-free DNA. So be very careful. Unless you're using a SNP-based NIPT, you will miss digynic triploidy. Massive parallel sequencing on NIPT will not pick it. You will be reliant on ultrasound. And a dilated fourth ventricle is probably one of the most powerful things you can look for. The single monoventricle isn't always easy. When you look at this case here, you can run that clip. Seeing the ventricle is very difficult. But when you look at the choroids are joining across the midline. There's no butterfly sign. This is very abnormal. And when you use a high-frequency linear probe, you can see that the choroids are fused across the midline. But it's a much more difficult diagnosis to make. And you may also look for a vessel underneath the skull called the snake under the skull appearance of holoprosencephaly is another clue. And they may also present with a proboscis. Again, sloping of the forehead posteriorly is a useful sign. And this is a case where we picked it up at 10 weeks of gestation, and this is a central facial cleft with holoprosencephaly. So we see holoprosencephaly. In fact, you know what I think? I think it is easier to make a diagnosis of holoprosencephaly between 8 to 10 weeks than it is acrania, because it's so striking when you see the single anterior monoventricle and the joint choroids and the absence of the falx. And we just keep going to the next slide. I just, in my interest of time, I'll skip these. And I'll skip that. Semi-normal holoprosencephaly is a very challenging diagnosis. But the forehead is abnormal, sloping of the forehead, big cerebral fourth ventricle is the clue, and then here's the single anterior monoventricle, but it's only joined anteriorly. There's posterior separation. Very difficult diagnosis. We move to the fourth ventricle, and I'm going to be very quick. The fourth ventricle, or intracranial translucency, has been described as a marker for spina bifida, small or absent intracranial translucency. But it is far more common in the first trimester to see a dilated fourth ventricle. And if you see a dilated fourth ventricle, you need to consider these chromosome abnormalities. You will have trisomy 18 in 53%, trisomy 13 in 80%, and digynic triploidy. If you do a 4-segment analysis of the brain straight away, you will appreciate that this is a big fourth ventricle, and there's a hypoplastic left heart. So that's either trisomy 13 or trisomy 18. If you do this scan, and when you look at this baby, you appreciate the bilateral pleural effusion, tachycardia, and a big fourth ventricle at 12 to 13 weeks, typically trisomy 13. Go to the next slide, please. We go to this one here. You can see a big cerebral fourth ventricle, a small abdominal circumference in a fetus with digynic triploidy. And in this one here, monosomy X, a big nuchal translucency, but a big fourth ventricle. So these common chromosome abnormalities will present with a big fourth ventricle, and that's far more common than seeing a small fourth ventricle. If you see a fourth ventricle that's big tomorrow morning, and you do a chorion biopsy and it comes back no chromosome abnormality, what are you looking at? Well, you could be looking at Blake's pouch. This is a big fourth ventricle. The chorion biopsy is normal. She comes back at 18 weeks. She's got a posterior fossa abnormality consistent with a Blake's pouch, and it fenestrates at 28 weeks, returning to a completely normal posterior fossa. This case, exactly the same. A big fourth ventricle at 13 weeks, but when you look at this case, not a good result, because the baby, if you run this clip, has got Dandy-Walker malformation at 20 weeks. Both babies presented with a big fourth ventricle at 13 weeks. Both babies had a normal chorion biopsy, but one went Blake's and the other one went Dandy-Walker. The problem is, I couldn't tell the patient at 13 weeks which way it was going to go. I didn't know. But maybe tomorrow, if I look at the aqueduct of Sylvius is obliterated in this baby with Dandy Walker. The aqueduct of Sylvius is dilated in this baby with Blake's patch. So maybe if you see a dilated fourth ventricle, you've got a normal result in choroidal biopsy. If you look at the aqueduct of Sylvius, it may give you a clue whether you're looking at Blake's, which carries an excellent prognosis for many, versus the Dandy Walker, which carries a terrible prognosis. Just might skip these and then move to spina bifida. I've already said to you that 30% of spina bifida can be detected by looking directly at the spine. But there are many different signs that have been described for spina bifida. These range from the dry brain, the reduction in the aqueduct of Sylvius, the reduction in the distance between the aqueduct of Sylvius and the occipital bone, and you can have parallelism of the cerebral lateral ventricles, where you can have a lemon-shaped head and a banana-shaped cerebellum. And on sagittal, it's exactly the same, multiple markers that are described. But for me personally, the most powerful marker for spina bifida is this marker, which we described in 2011. And if you can run the clip, stop, just don't run it yet. Everybody in this room knows that that looks like a normal BBD, because you all do BBD measurements. This is where the thalamus is. This is where the thalamus is. This is where the cerebral peduncle is. Now play the clip. Go back. Can you run that clip? No, no running. Okay. So if you look at this clip here, if you can run these, it's shifted posteriorly. When you look at that BPD, this should be there, not there. And there's no visible aqueduct. This baby has got spina bifida. And I think it's so easy because everybody in this room knows what a BPD looks like. But the whole midbrain is shifted. So it's juxtaposed to the occipital bone. That is a very powerful marker. When you are faced with this situation where a baby has got shift, that is abnormal. There's no aqueduct, but the brain's not dry. There's fluid still there. And I cannot see the spina bifida. What do I do? I can't see the spina bifida, but the head signs are there. If I cannot see a spina bifida, I cannot make a diagnosis. The head signs are not a diagnosis. They're a sign to look at the spine. So what do you think I did? I said, oh, well, I can't make a diagnosis. I need to bring the patient back. And I bring the patient back 1 week later, and now I see there's a banana-shaped cerebellum. And when I come down to the level of the kidneys, I see the defect of the skin. I had to wait for a week later. I had to do a vaginal scan, and I had to convince myself. 20% of spina bifidas will be on myelocele. 80% will present with a bubble in the spine, a meningomyelocele. So they can be very challenging. So let's skip this. We also reported on the maxillo-occipital line. So if you look at the junction between the thalamus and the mesencephalon, you see that should fall above the maxillo-occipital line, whereas the spina bifida, it falls below. And that's been published recently in a Chinese study that shows one of the most powerful markers of spina bifida. I'm going to finish the talk and say a few words about hydrocephalus. There are a number of ways of seeing ventriculomegaly in the first trimester. One is to measure the area of the choroid to the area of the lateral ventricle and divide one by the other and use Guerrero's chart. The other way to do it is to take the length of the choroid and take the length of the ventricle and then use the chart of Mangold-Brower. But for me, I don't take these measurements because I rely on subjective assessment. If the subjective assessment is abnormal, then I will go to the charts. This baby's choroid occupies less than 50% of the lateral ventricles. That is abnormal. So when I see ventriculomegaly like that, I then go ask myself, are there any other markers for trisomy 18, 13, or 21? This is a baby with Down syndrome, bilateral pleural effusions, and ventriculomegaly in a fetus with T21. And this is a fetus who you see, in this case, on the right-hand side, you see the ventricles are enlarged. And so it's not a dry brain, but it's the opposite, and you think of ventriculomegaly. And when you look at the cerebellum is reduced in size. So this is ventriculomegaly in the first trimester with rhomboencephalous synapses. Be careful of cord plexus cysts. They are present in 1% to 2% of pregnancies. And when you do see them, make sure you go looking at the rest of the baby. So this is the baby I saw, and the 2nd of May a few days ago, and an corplex cyst. But I looked at the rest of the baby, and then I see that it has a cleft lip and cleft palate. So if it's isolated, a corplex cyst, I don't worry about it. But if I see this corplex cyst bilaterally and a facial cleft, then I offer a chorion biopsy looking for trisomy 13. So that's my message there. You cannot make a diagnosis of agenesis of the corpus callosum before 14 weeks of gestation. Yes, you can see signs by seeing that the pericallosal artery is abnormal. Yes, you can see that there's ventriculomegaly, and we reported this case of ventriculomegaly in 2023 in a baby who turned out to have agenesis, but we did not make the diagnosis at 13 weeks. This is what it looked like at 13 weeks. And this, when she came back, she had agenesis of the corpus callosum. But the problem is, if you cannot make a diagnosis, looking for the pericallosal artery, looking for ventriculomegaly, looking for an increased brainstem height, these are not useful, I don't think, unless there's something else that goes with them. So, where do we stand today? We stand today in Vietnam in 2024, where we understand that approximately 2/3 of major brain abnormalities may be presented in the first trimester of pregnancy and may be detected with a very high detection rate. And of these brain abnormalities that are in the 2/3, many of these are severe, lethal, and incompatible with survival. Patients want the diagnosis early. They don't want the diagnosis at 18 to 20 weeks. And for the minor abnormalities that you pick up from the brain, they want to know about exome sequencing, not at 26 weeks of gestation. If you are suspicious about an agenesis of the corpus callosum, they want the diagnosis a lot earlier. Isolated agenesis of the corpus callosum, approximately 30% of patients will have a finding, an abnormal monogenic disorder on an exome sequencing. Now, we are routinely offering that for patients in the mid-trimester, but if you have suspicion about it before, it may allow you to get moving. When you go to work tomorrow morning, my last slide is the most important slide, is to take a 4-section analysis of the brain, identifying all these landmarks. Take a 3-segment analysis of the fetal brain, looking at the 3 spaces in order of size of the spaces. The brainstem, the intracranial translucency, and the cisterna magna. Just look at those. If you're going to measure something, measure the intracranial translucency. Thank you very much for your attention.